Sorry. Um, I'm Rebecca Armstrong, the Director of Patient Education Engagements with the Canadian Breast Cancer Network. This session is being recorded and it will be available on our website for anyone who may have missed it. I'll send out a link once the recording is available. You will be able to find previously recorded webinars that address a variety of different topics on our websites. I'd like to extend our sincere appreciation to our sponsors for today's session, who provided support through unrestricted educational grants. Pfizer, our gold level sponsor, the Canadian Lymphedema Framework, our silver level sponsor, and Bayer, Tiercera, and AstraZeneca, our bronze level sponsors. The format for today's session will be a presentation by our expert speaker, followed by a question and answer period. Please feel free to submit your questions throughout the session using the Q&A function that you should be able to find at the bottom of your screen. Our speaker today will do her best to answer your questions, but please note that she may not be able to speak specifically to individual situations without having a complete medical history. I'd now like to welcome our host for today's session, Kathy Amendolia, the chair of the board for the Canadian Breast Cancer Network.
And thank you, Rebecca. Welcome again, everyone. Thank you for joining us today. I'm pleased to welcome and introduce our expert speaker, Dr. Siba Hakel, who is the Section Chief of Reconstruction Oncology for the Division of Plastic and Reconstructive Surgery at Yale Medicine. She is an acclaimed specialist in microsurgical reconstruction and has research interests in breast reconstructive surgery. Dr. Hakel has years of experience delivering care for breast cancer patients. She specializes in autologous-based reconstruction and has extensive experience in treating lymphedema. Dr. Hakel, great to see you, and thank you for being here today.
Thank you so much. Thank you, everyone, for having me. I will start sharing my screen. Okay, please let me know if this works. Great, thank you. So today I'll be basically splitting my talk into two and really focusing on breast reconstruction and lymphedema. So I have my practice involves a lot of microsurgery. So I'll touch a little bit more on what that means, but also involves all different forms of breast reconstruction. So let's start with breast reconstruction. So the timing of breast reconstruction is typically divided into immediate, which means at the same time as the mastectomy, which is the removal of the breast for cancer, or delayed, which means any day after the mastectomy. What are the factors that affect breast reconstruction decision? So typically, we look at patient preference, and this is in conversation with our patients, the need for postoperative treatments, such as chemotherapy or radiation, available donor sites, and I'll touch a lot about what that means in a little bit, other medical issues, and recovery time. So recovery time is different depending on what type of reconstruction we choose. I first want to talk about other areas where plastic surgeons are involved. So there are some instances where a patient is not interested in having a breast mound after mastectomy, is not interested in implant or using their own tissue, and would rather have a flat chest. And we're definitely seeing more and more of this. And there's something that the plastic surgeons are involved in. It's called aesthetic flat closure. So what does that mean? It means that the plastic surgeon would be involved at the time of mastectomy to make sure that the incisions and the scars are very linear, that there's no redundant skin that is present or available, and that patients can still feel nice in their skin and have a flat closure that heals well. So frequently, plastic surgeons will be involved in performing an aesthetic flat closure. Another type of reconstruction is called oncoplastic reconstruction. So what does that mean? So oncoplastic reconstruction is typically done at the time of lumpectomy. So a lumpectomy is where we remove a portion of the breast tissue, where we don't perform a full mastectomy, which is the removal of all of the breast tissue. And then a plastic surgeon would be involved in removing that area with the breast surgeon, but also rearranging the tissue in order to achieve a better aesthetic result. So when a portion is removed, typically it can cause dimples and divots in the breast, and it can cause pretty significant asymmetry between two breasts. So this is a good option for patients who have very large breasts or very tautic breasts, so saggy breasts, for example. A breast reduction and a breast lift at the same time as the cancer is removed. And you end up with nice scars around the areola, a scar like a lollipop, and a scar in the fold like an anchor, and it helps lift the breast at the same time. And what we typically tend to do is also operate on the other side, so the breast that doesn't have breast cancer, so that we can match both sides. So one type of technique for reconstruction is what we call implant-based reconstruction. So what does this mean? So one way of doing it is that at the time of mastectomy, we put an implant right away. So this eliminates the need for what we call tissue expansion. And I'll explain that a little bit more. This is where breast reconstruction is performed in one step. The patients who are candidates for this really depend on their breast size, the tumor size, so the size of the cancer, and the type of mastectomy that is required, meaning are we keeping the nipple? Are we removing the nipple in the areola? Are we making incisions in the fold or around? This is not gold standard because it can have high revision rates, but this is more frequently used. The gold standard for implant-based reconstruction is a two-stage procedure. So what does that mean? So typically in the first stage, a tissue expander, which looks like something like this. So it's made from silicone on the outside. It has a port. So this is a magnetic port. There's a magnet that sits in there. It's placed either above or below the muscle. So most commonly nowadays, we put this expander above the muscle. And then the skin is actually covering that expander. And this requires that the patient comes into the clinic every week, and we use a magnet finder, and we put a needle into the port, and we fill this expander like a balloon. So our goal is to expand and push the skin to the size that the patient is interested in. So this allows for patients who are smaller to want it to be bigger, and it also helps us temporize the area, for example, in the context of radiation, for example. But this procedure requires two stages, meaning that at the first stage, the tissue expander is placed, the area is expanded, then we have to wait a particular amount of time before we go back to the operating room, remove that tissue expander, and put a permanent implant in. So this is an example of a tissue expander, which is sometimes covered with what we call an alloderm sling. So this is mesh or a piece of skin. And then we allowed about 2 weeks for things to heal. The expansion process takes about 8 to 12 weeks. The variable amount of months really depends on whether or not radiation is also required. If radiation is required, then we wait about 6 months before we go back to exchange the expander for a permanent implant. And this figure right here represents the exchange for a permanent implant. The implants that I typically use are silicone implants. So this is what an alloderm sling looks like. Basically, it's made from cadaveric skin. So the cells have been processed, they've been removed, they've been rendered safe to use. This is an example of what a tissue expander would look like. So the tissue expander actually looks really fake. It sits high, it sits tight, it's filled with saline. It can be a little bit painful. And then at the time of exchange, the expander is removed and an implant is put in. The implant is made from gummy bear silicone. So if you cut into it, the silicone doesn't go everywhere. And it gives a nice shape and it's much softer. What are the complications with tissue expander and implant-based reconstruction? So in most cases, there are no complications. However, they tell us the shelf life of an implant is about 10 to 20 years, 10 to 15 years, which means that it's possible that in 10 to 15 years, these implants would have to be removed or exchanged for new implants. The body also sees an implant as a foreign body. So what does it do is it walls off this implant, and it walls it off using a capsule. So it's a very distinct layer of cells. And sometimes that capsule can get hard, can get tight, can distort the implant, can make it very painful. That's called capsular contracture. That happens in about 7% of cases, even for patients who undergo this for breast augmentation, so an aesthetic procedure, but it can also happen in breast reconstruction. And it can also happen in the context of radiation. And in that case, the chances of capsular contracture can go up to about 30%, which is actually quite high. Other things about breast implant reconstruction is that you can have some wrinkling or what we call contour irregularity. There's always a risk of infection, especially with a foreign body, a blood collection, which is called a hematoma, or a fluid collection, which is called a seroma. So this is an example of a patient who had what we call a skin-sparing mastectomy. So her nipple and her areola were removed, and we did a direct-to-implant reconstruction where we placed an implant at the same time. And she's slightly smaller in size due to the fact that we had to remove her nipple and her areola. This is an example of a direct-to-implant after nipple-sparing reconstruction. So the nipple and the areola are preserved. The incision is located in the fold right here, and an implant is placed at the same time as the mastectomy. This is what radiation can do. So radiation can create some redness in the area. It can cause some distortion of the implant. It can cause the implant to get hard, can get tight, and get painful. So what are the advantages of implant-based reconstruction? So typically, it's a quicker procedure. It's a shorter recovery time. You get to choose the size of your reconstruction. We're only operating on one site. The disadvantages is that it requires more than one surgery if it's not done direct to implant. You can sometimes see and palpate the implant. You can have what we call chest wall muscle animation, meaning the muscle can get contracted. There's a risk of infection. There's a risk of capsular contracture. There's a risk of rupture. Radiation can lead to a higher failure rate. There's also two things that have been discussed with breast implants. One is called anaplastic large cell lymphoma. So that's when a fluid collection forms around a certain type of implants. These are typically textured implants, which I personally have never used in my practice. But if you send that fluid out, it can come back as positive for markers of a lymphoma, which is cancer. It would require the implants and the capsule to be removed. We also know that some women don't do well with breast implants. There's something called breast implant illness, which means that they do not feel well with implants put in. We don't know why that happens. And sometimes the patients feel better after the implants are removed, but sometimes they don't recover. We think it might be related to an autoimmune disease. So frequently, and pretty much on every case, I assess the mastectomy flap before I put in a tissue expander or an implant. So some of the techniques that I use are perfusion studies using fluorescent dyes, which help me figure out whether there are any areas where there's very low blood supply. If there's low blood supply, then I'd be very worried about putting in a tissue expander or an implant. And I can use also some quantitative measurements to figure out the blood flow that is going into the area to make sure that it's working well. There's also, I talked a little bit about the nipple-sparing mastectomies, which is an amazing way for some patients who are candidates for it, meaning they don't have a lot of saggy breasts. But there's also a technique that we do where we try to preserve sensation to the nipple areola. When a mastectomy is done, we frequently lose the sensation. Actually, not frequently, we always lose the sensation to the nipple areola. And we can sometimes find a nerve that comes from the side. We use an allograft or an autograft, meaning either a cadaveric nerve or a nerve from the patient, and we swing it over and we help connect it to some nerves that are still intact underneath the nipple. So these are new techniques to bring back sensation to the nipple. Now let's talk about autologous tissue reconstruction. So what does this mean? Autologous tissue means using your own body to reconstruct. So one of the areas is the abdomen, which is the belly. The other area is the buttocks, the thigh, the groin, and the back. Those are different areas that we can take it from, and the flaps are called different things. So those are the areas, as you can see. From the abdomen, you can get what we call the DIEP or a deep flap, an SIA flap. From the thighs, you can get a tug flap or a PAP flap. From the buttocks, you can have an S gap or an I gap. And from the lower back, you can have an L cap. And from the back, you can have a Tdap or latissimus dorsi. So let's explain what this means. So this means that we're using the patient's own tissues to create a breast mound. It really avoids all the complications of implants, and it's a pretty nice donor site. So let's talk about the deep flap or DIEP flap. Basically, this is very similar to a tummy tuck. However, we take the vessels and we take the skin and the fat from the area and we disconnect it and we reconnect it in vessels that are located underneath a small piece of a rib. So let me show you what this means. So a tram flap is one of an older techniques where the whole muscle, along with the fat and the skin that sits above it, is taken and tunneled underneath the skin of the chest to bring it into the breast and to make a breast. Well, that's a much older technique. The new technique of a deep flap or DIEP flap is where we disconnect the tissue. So how do we do that? So this is a cross section of the muscle in the belly. There's a vessel called the deep inferior epigastric artery, and there's two veins that come with it. And they run underneath the muscle. They come from the groin, and they give off small little vessels that are less than 1 millimeter in size to the skin. So we typically get imaging of the belly first to make sure those vessels are there. If people have had scars or abdominal surgeries, they're typically still candidates for it, depending on what kind of surgery they've had. A contraindication would be a tummy tuck, because during a tummy tuck, all that tissue is actually removed and discarded. So those little vessels are found. We use loops and a microscope to do the surgery. We find those little vessels during the case. We follow them underneath the muscle. We disconnect them from the groin and we reconnect them in vessels that are underneath a small piece of a rib of cartilage. So you end up with a scar from hip to hip and scar around the belly button, and obviously a scar in the chest as well. And what I also try to do is also use a nerve to reconnect the nerve to a nerve in the chest wall to try to bring back sensation. And I've done this in a lot of patients, and some of them, even despite connecting a nerve, even without connecting a nerve, they tend to get sensation as nerves can grow from the sides. So one side surgery takes about 6 to 8 hours. Two sides takes about 10 to 12 hours. The hospital course is about 2 to 3 days. The most important thing is the first day to watch to make sure that that connection of the artery and the vein are actually working really well. So the patients are monitored very frequently every hour. They're also monitored using what we call a Doppler. So we check to make sure that there's good flow. We also can use external devices to monitor this flap. We call this a breast flap. And what are the possible complications? So in almost 80% of the time, there are no complications. Because we're operating within the muscle of the belly, we try not to take any muscle. There's a risk of a hernia or a bulge. there's a small risk of delayed wound healing, of infections, of blood collection or fluid collection, just like any other case. And there's a small risk of losing this flap completely, meaning the connection doesn't work despite trying to fix it. So it's a less than 1%. So this is an example of a patient. This is before their mastectomy, where we removed the nipple areola and removed all the breast tissue inside, and the skin was left behind. So we take skin and fat from the belly, as you can see from the scars, and we put them into this area and we connect them. And we leave a little circle so that we can monitor the flap to make sure that it's still working okay and has good flow. We can do this in patients of different shapes and sizes. Now, delayed reconstruction for autologous reconstruction is done at a separate operation after the mastectomy, can be done months to years later. So this is someone who came with scars and scars only. As you can see, this patient was heavily radiated. This is radiation damage right here. So I would typically not use an implant or expander in this. Ideally, the best option is to use the patient's own tissue. And we use the patient's own tissue to create a breast. And in this case, because it's a delayed reconstruction and the skin has already sunken in, we have to use more skin from the belly to create that tissue. So a delayed to immediate deep reconstruction is when we know that there's a possibility of radiation. And we want to maybe temporize the area so we can preserve some of the skin and then later perform an autologous reconstruction. So we would put a tissue expander at the time of mastectomy, and then we would remove an expander later, the expander later, and then perform the deep reconstruction at a later date. The advantages of autologous tissue reconstruction using the belly is that most of the reconstruction is done at the time of surgery. We use our patient's own tissues. It's a lifelong substitute for a natural looking breast. The benefit is a tummy tuck. The disadvantage is it's a longer procedure. It's a longer recovery time. It's a separate donor site. It may require revision surgery. You can lose the flap. I can only use the belly once, which means that if two sides are necessary, it's important to do it at the same time. And there's more scars. There's other areas that, as I mentioned, where we can take the tissue from. The S-gap is from the thigh, the tug, and then the pap flap. Those are from, the S-gap's from the buttocks, and the tug and the pap are from the thigh. So let's talk about using implant in combination with autologous tissue. So this is reserved typically when we have maybe a partial mastectomy with a divot. We take some skin and fat and muscle from the back and we swing it over with an expander. And eventually we'll also need an implant. So for example, this patient came to me, she'd previously had a lumpectomy done, and she had loss of tissue in that area. And so I brought over that flap along with an expander and eventually an implant to give the patient a better aesthetic result. And this is a patient who was flat on both sides, was really interested in implant-based reconstruction, however, was heavily radiated on both sides. And we did back flaps with implants and expanders and implants. So the advantage of this is it can be used in patients that have previously had radiation. It can be used in patients who are too thin or have previously had a tummy tuck. The disadvantage is it comes with all the risks of implants and all the risk of using tissue from another part of the body. Let's talk about making the nipple areola. So we heard about some instances where we can keep the nipple and areola, but in some instances, and most commonly, it is removed. So a nipple reconstruction is completely elective. It's done no earlier than about 3 months after the initial reconstruction. It can be done under local anesthetic. It's a short recovery time. And then we can do areolar tattooing, which is done later. So the way to do it is we can bunch up some skin, kind of like origami, and make a nipple out of it. It kind of looks like something like this. It's not like a normal nipple. It doesn't change with heat, cold, sensation, or anything else. But it looks like there's a bit of elevation. And then I personally have a APRN that I work with, but there's a lot of certified tattoo artists and who do this, and then they would tattoo the area. These are different examples of different pigments and different colors. And then there's an option of not performing the elevation, but performing a 3D nipple areolar complex tattooing. So this is without the elevation. This is just a tattoo that makes it seem like there's an elevation. So that was breast reconstruction. Let's now talk about lymphedema. So the pathophysiology of lymphedema is that initially there's accumulation of protein and inflammation, fibrosis, which eventually leads to a sustained inflammatory response. So this can happen after some patients can either be born with it, it can happen while they're in adolescence, or it can happen later on when they're adults. That's called primary lymphedema. Secondary lymphedema is when it happens after either an infection, which is most common around the world, or in our parts of the world, it can happen after surgery. So that surgery would involve possibly removal of a lot of lymph nodes. And then there's some really particular risk factors that can predispose someone to lymphedema, which I will talk about and go into more detail. But chronic lymphedema and even acute lymphedema, there is no cure. It's a chronic condition. It's very debilitating. And it is on a cellular and physiological level, it's a sustained inflammatory response, which eventually leads to accumulation of fat. But initially, it's not fat dominant, meaning that it's fluid, it's lymphatic fluid dominant. But eventually, that leads to what we call dilated and fibrosed lymphatic vessels. The management is really a multidisciplinary approach. For the secondary lymphedema patients who are cancer patients, it really starts at the time of diagnosis and throughout all years of life. The most important thing that I really want to focus on today is that early assessment, prevention, and surveillance are how we are going to be treating lymphedema and what we should really focus on. A referral for exercise and rehabilitative therapies is important. Early physiotherapy, this not only reduces the economic burden associated, but it also prevents things like hospital admissions and infection. And education, which is promoting positive self-efficacy strategies that reinforces the survival's ability to control lymphedema through early detection and early rehabilitation. Now, as you know, I'm a surgeon. So as a surgeon, it's important for me to also talk about surgical techniques, but I always talk to my patients who have lymphedema that the management centers on combined decongestive therapy. It's a CPT, CDT that involves multiple different techniques, but mainly focusing on manual lymphatic drainage and compression. Manual lymphatic drainage is very effective. It obviously depends on the type that is being used. And compression allows to reduce the pressure and the flow in that arm, limb, upper limb or lower limb, which reduces the lymphatic load, and it really encourages the lymphatics just by virtue of pressure to really and any form of muscle movement. So this looks like bandages and garments, which are excessively important. I stage lymphedema, and staging is extremely important. There are different ways to stage them, but this is the staging consensus that I use, which is adapted from the 2013 consensus of the International Society of Lymphology, where at stage 0, those are patients that are at risk of developing lymphedema. Those are the patients that we have to follow very, very closely and make sure that we are following them throughout to ensure that they do not develop lymphedema, and if they do, that we have the appropriate people on board to help them through this. For stage 1 and 0, so that goes from pitting edema to non-pitting edema. There's a lot of physiologic techniques that are available that can help with that. And then There are things like liposuction and resection surgeries that are possible for other stages. So these are what the stages look like. So stage 0, where we don't always see any changes in volume. However, that's where symptoms actually start. So people will start saying that either they have pain, they're uncomfortable, there's a lot of different issues. You know, some people will tell them, oh, this is nothing, this is maybe surgical related, but what we should really be picking up on is that these are early signs of lymphedema. And eventually we go through the different stages of pitting edema to non-pitting edema to fibrosis. We have a lot of skin changes that go from mild skin changes to which is high protein edema. There's firmness in the skin, and elevation can help, to moderate skin changes, which is spontaneously irreversible. There's some hardening, to very severe, which is what we call elephantiasis, and there's a good amount of fatty tissue that forms at that stage. If we were to look at the lymphatic vessels are typically really, really small. They're less than they're 1 millimeter and less in size. And if we look at them under the microscope, we can see that a normal lymphatic is translucent. You know, you can see some flow that goes through it. Eventually, as we go along in this different stages, there's progression and dilation of these vessels. And then there's what we call the contraction phase, which is the different areas around the lymphatic vessels that get hypertrophied or much larger. And eventually they become completely sclerotic. So our goal is to be able to really try to keep the lymphatics at this early stage and prevent them from the contraction and the sclerosis stage. How do we do this? So one of the important things is imaging in the context of lymphedema. The question is, does the lymphatic system still work? So how do we determine that? We determine that on clinical examination. So the absence of edema, the presence of pitting edema is very important. As we talked about, this represents an early stage. And then it's important to do certain things like lymphoscintigraphy, which is the injection of a radionuclide dye in the web spaces of the feet or the hands, and to watch the flow into the lymph nodes. So here we can see at stage 0, linear flow to the groin, where we can see the lymph nodes. At stage 1, we start seeing in this limb that there's some dermal backflow, but eventually we see the lymph nodes. At stage 2, there's a lot of dermal backflow and we barely see the lymph nodes light up. And at stage 3, there's no flow whatsoever. And this is the other limb where there's complete obstruction. So that's how we determine flow. There's another way to determine flow, and that's by using what we call ICG, or indocyanine green. And there's different patterns that we can look at. So it can vary between a normal to splash to stardust to diffuse. What does this mean? Let me show you an example of one of my patients. So this patient was injected in the operating room, but I frequently do this in the clinic as well. So a little bit of dye is injected in the web spaces, and we can see that there's start of a linear flow, and this flow actually eventually stops at the level of the elbow. So it ranges from splash to stardust, different patterns to diffuse. And we know that everything above that, the lymphatics are not working, but we know that the lymphatics underneath there are actually possibly working. And that helps us determine where are we going to perform our surgeries. I'll talk about the option of surgery in a little bit, but at least the imaging helps us define where potentially we have working lymphatics. So this is an example of a lymphatic. It looks blue because I've injected the area with blue dye to see the lymphatics under the microscope. And this is a small vein. So why are we doing this? So a lymphovenous, this is called a lymphovenous bypass. It can be done either by connecting a lymphatic to a vein, side to side to end to side, or end to end. What does this do? So it's a microsurgical technique. So these lymphatics are less than 1 millimeter in size. of lymphatic vessels to small superficial veins to shunt the lymph fluid into the venous system. So our goal is to have the venous system actually pick up that fluid. The theory is that this anastomosis or connection that we perform remains open if the lymphatic pressure is higher than the venous pressure. And this is best performed by making sure that we use the veins that are appropriate, that don't have too much flow. And from a lot of the work that's been done, we think that this can reduce the lymph volume by about 35% at 1 year. There's another technique. This is called a vascularized lymph node transplant or transfer, where we can take healthy lymph nodes from the groin, from the abdomen, from different areas, from the neck. And these are taken very similar to that deep flap that I talked about earlier, that autologous tissue. So we take the lymph nodes and we take the artery and the vein, and then we hook them up in the axilla to help reduce the swelling in that area. So how does this work? So typically this is reserved for later stages, and in most cases where there's a lot of scar, the recipient bed is prepared by removing the excision, followed by a flap that is using these nodes. And these nodes, like I mentioned, can be taken from different donor sites. So the omentum, that's the abdomen, the groin, the thoracic area, or the cervical area. So the transfer of these nodes will actually produce these growth factors, which will promote lymphatic vessels that are already in that area to form new connections. And the removal of the scar from that area will actually promote immunological function, meaning reducing the risk of infection, serving as an interflow between the lymphatic and the venous system. There's no data that really shows that new lymphatic vessels are starting to regenerate, but our goal is to produce the risk factors. So now there's another technique. So those are the two techniques that I just described are for the patients who currently have lymphedema. What about the patients who don't have lymphedema, but are getting a full axillary lymph node dissection in the context of breast cancer, or getting a full groin dissection in the context of skin cancers or pelvic surgery or a gynecological procedure? So there's a technique called immediate lymphatic reconstruction, which is done very similar to what I previously described of the lymphovenous bypass, but we do this prophylactically, meaning we do this to prevent any arm lymphedema from happening. And this is actually quite important. Okay. So what is the algorithm for treating lymphedema? So the phase 1 really focuses on CTT and CPT, and if anything, that's a lifelong phase. We would require people to have done it for at least 6 to 12 months really well, and then we would proceed to microsurgery and rehabilitation. There's also different indications. So I talked about prevention and I talked about treatment. So I want to talk a little bit about some of the work that we're doing in terms of research, and I'll spend the last 10 minutes really focusing on this because I know everyone has a lot of questions and I've been talking for quite some time. But there's a lot of interesting research that I'm leading and also involved with in collaboration with other areas where we're looking at what makes people more susceptible to lymphedema. So we know that there are potentially some gene expressions and some particular risk factors for that. So we looked particularly at what we call PPARs, which are peroxisome proliferator activator receptors. We know they're much higher in lymphedema. And when we took samples from the control arm and the lymphedematous arm, what we noticed is that there was an increase in some particular interleukins which are involved in inflammation. So we're definitely looking at a lot of that, doing a lot of that work to try to find a biomarker for lymphedema. Why do certain patients develop it and not others? Also, another interesting work that I've done with some of the members from Stanford is to look at what we call qualitative outcomes following this type of surgery. So we focus a lot on the reduction of volume, but what's very important is how do patients feel afterwards? So what we did is we conducted interviews with patients who have had the surgery. So we talked to them prior to surgery and after surgery. And what we focused on was quality of life, psychosocial well-being, symptoms, function, and surgical experience. And I'll show you some of the results. So our patients were mainly female with stage 2 lymphedema and had a history of cancer. What we noticed is that their quality of life score after surgery increased by quite a lot, and we'll go through some of the detail. Preoperatively, they were very limited in terms of their activities of daily living, with many of them had their lymphedema having an impact on exercise, on mobility, and limited activity. And there were just things that patients could not do anymore, as represented by this quote. In terms of physical symptoms, 91% reported swelling and 60% reported pain, which is very hard on my mental health. Psychosocial impacts, we looked on impact on low mood, and 55% of patients had anxiety. Some of them had anxiety related to their upcoming surgery, but mainly about the uncertainty of disease progression. Cellulitis, 41% of our patients experienced cellulitis, with most of them having more than one episode. And then we looked at different treatment modalities and treatment challenges, and patients definitely do not like garments, but I think we all agree that we all think garments are important, but they talked about the distress that garments actually provided them. And when we looked post-operatively at our qualitative findings, we found that after surgery, about 88% reported reduction in heaviness, 83% reported pain reduction, volume reduction, and reduction in discomfort. And in terms of their functional impacts on lymphovenous anastomosis, they were able to lift heavier things, do more groceries, moving things, more rigorous cleaning, for example. 75% reported a positive change in their appearance. 50% reported that they feared that their lymphedema would return, and 50% said that they had mood improvements. And obviously, we also use post-operative bandages, and patients did not like the post-operative bandages. The reasons for seeking out surgery was really for symptom control because they've exhausted other therapies, and 30% had a PT referral. The meaning of surgery for them was that it was for symptom and situational improvement. It gave them hope, and many of them felt gratitude. In terms of data synthesis for this type of work, we looked at different models of care, and we think it's important to really screen patients for eligibility, really develop a perioperative education, rehabilitation, psychosocial support, and really assess outcomes over time. I want to talk briefly about some of the disparities in breast cancer-related lymphedemas. We performed a systematic review of the inequities and barriers in care. We found that we were looking specifically about whether or not diverse and disadvantaged patient populations had an effect, because this patient population continues to be understudied. We performed rigorous methods in order to look at that. And what we found was that so there is racial and ethnic disparities. There's an increased risk with certain sociodemographic factors, such as younger age, low education level, low income, rural geographic location, and presence of medical comorbidities. There's inadequate provider and patient knowledge. There's low patient education. There's a lot of barriers in the receipt of healthcare provided to even give patients a diagnosis of lymphedema. And the sub-themes that we looked at included cost, psychosocial barriers, and the role of patient self-efficiency. So younger, non-Caucasian patients located in rural geographic regions with low income and education appear to be at higher risk of self-reported rather than physician-diagnosed breast cancer-related lymphedema. Patients of diverse racial and ethnic backgrounds had inadequate self-care, practice education, they had insufficient breast cancer survivorship support, and they had low accessibility to treatment resources. And although the mechanisms that increase the risk in this patient population are not studied, I think it's important to really, really try to promote us educating these patients and even diagnosing them. I also want to talk about some of our predictive models. This is a lot of the work that I'm doing at Yale, because Yale, before I got here, had historically had a large cohort of axillary lymph node dissections, which gives us access to over 16,000 cases. It's actually more than this number stated. And so, as we talked about, there's a lot of prediction models that are out there. There's about 38 models that have been developed so far. However, there's no clinically applicable method that currently exists to predict which patients will develop lymphedema following axillary lymph node dissection, or when will it occur. So the limitations of the current models are that they don't predict time to diagnosis. They're based on relatively small cohort, and they lack statistical power. They have a short follow-up period. They don't account for race and ethnicity. They don't address comorbidities, and they don't include laboratory predictive models. So we need more information. So we aim to really look at that. We wanted to look at the impact of demographics and clinical variables on the risk of developing lymphedema, and we wanted to explore laboratory-based models to look at the effect of that. So we want to look at risk, but we also wanted to look at time. When are people developing lymphedema? So again, we did the same thing. So this was a decade-long study, really aimed to identify these predictors, and we wanted to develop an algorithm to study that. So it was a retrospective review. We included patients for 11 years. We looked at age, BMI, gender, race, chemotherapy, radiation, diabetes, and several different outcomes. We did different statistical analyses. About 15% of the patients in that cohort developed lymphedema, which is typical. And most of these patients developed it about almost 2 years after axillary lymph node dissection or surgery. So what was interesting is that the independent risk factors for lymphedema development was a BMI of over 30, chemotherapy, diabetes, Black race, and radiation. And the early predictors were Black race, Asian race, and radiation, and the late presentation predictors was diabetes. And then when we looked at our laboratory-based model, the independent risk factor for lymphedema development was a BMI of over 30, chemotherapy, and hemoglobin A1C, which is a marker for diabetes. And when we looked at late presentation predictors, it was a BMI of over 30 and hemoglobin A1C. So this is the largest single center study to provide clinically applicable prediction algorithms for an individual risk and time to diagnosis. It's the first study to highlight hemoglobin A1C, and these findings really offer a foundation for individualized screening protocols and early prevention methods. And there's a lot of future studies that we are really looking at to really improve multidisciplinary approach to treatment, really enhance early diagnosis, because we believe that that's really important to really prevent barriers and disparities in care, to identify novel biomarkers. I think it's important to establish predictive techniques as standard of care, and to really create individualized predictive models. Thank you so much to everyone for listening. I know this talk was very long, so I look forward to all of your questions.
Thank you so much. That was a very in-depth presentation that touched on some information that I'm sure a lot of us were not aware of. I'm going to start off because I know we have questions from our participants listening. But I'm going to start with a couple of questions on the lymphedema since we're just coming off that. So it used to be where where you were told, no, let me backtrack. Are the physicians explaining lymphedema to patients before the surgery and before their journey of treatment? Because it seems that they've improved, but not that much in that area.
Yeah, I think that's an important question. And I do think that things have really changed. Now, I think definitely when I discuss it with patients and when surgeons, like breast surgeons, for example, or melanoma surgeons, when patients are going to be undergoing lymph node dissection, it is definitely discussed and it should be discussed. Now, I'm not sure that they're given all the information related to what the risks of developing lymphedema is going to be. And the reason for that is because a lot of institutions don't even have that information. And I think this is why we're really pushing early diagnosis, but really prevention and education. So, for example, all of our patients at Yale who are undergoing axillary lymph node dissection are automatically getting immediate lymphatic reconstruction. Because although we cannot promise them that the risk of lymphedema is going to be zero, we know that the benefits outweigh the possible risks of that surgery. And we potentially would be able to reduce that risk of developing lymphedema by about 50%. So I think what's also interesting is that there's a lot of people who still don't know that there are possibly some surgical techniques that could be offered for these patients. But I think we can all agree that we should try to focus on prevention more than anything.
And that's why I asked the question, because I think that that area is a little bit gray in terms of patient getting that information and understanding, lymphedema, especially after having lymph nodes dissection. Now, in terms of that, it used to be where your doctor would say, please don't have any blood tests taken from that arm or your blood pressure, et cetera, and people follow that rule.
Yes.
Does that have any significance in terms of preventing? And my in the same question, is everybody at risk, or does everybody have some lymphedema after having a lymph node dissection, but it's so minimal that it does not go anywhere? Can you touch on that a little bit?
Those are amazing questions and very important questions. So let me address the first one. Blood pressure cuff, putting an IV in that arm or anything done to that arm, we actually know that it does not increase the risk of lymphedema. It also doesn't, is unlikely to, lead you to lymphedema. However, part of lymphedema care is making sure that if you've ever had lymph nodes in that arm, or if you have any kind of pain, or if you have any swelling, is skin management and skin care. So anything that has the potential of creating an injury to your skin or causing an infection can likely trigger. So automatically, I still would follow those rules because I think that's part of the whole management of lymphedema. A big part of it is, hygiene, proper skincare, and all of that. And it's not necessarily based on the fact that you will either develop lymphedema or your lymphedema will become worse. But anything that has the potential of trauma to that limb, if you already have lymphedema, can make you susceptible for an infection. The other part of your question is, I definitely do believe that yes, anytime lymph nodes are removed from anywhere, we do a lot of head and neck surgery, head and neck cancer. People actually remove a lot of lymph nodes. Initially, there's a period of swelling. That period of swelling, I don't think is necessarily lymphedema, because lymphedema is abnormal swelling. But I do feel that everybody will undergo that period of swelling. Now, following that period of swelling, there's a trigger where it goes to a phase where it is no longer reversible. And I think it's either related to genetics or autoimmune disease or something underlying that we just haven't figured it out, which is why we're so interested in these biomarkers, where you go from this period of post-operative swelling and edema to lymphedema. So definitely everyone will have that. I just don't think I would characterize it as lymphedema. But interestingly, patients who develop lymphedema will actually point to one particular area, typically, where they started feeling pain or discomfort. And before they even feel the swelling or see the swelling. And if we do certain imaging, like the ICG lymphangiography that I talked about, we can actually start seeing abnormal channels that are there. So it's really interesting that there's a particular area of the skin where these changes actually start. And it could be, obviously a lot of the work is done in the axilla, for example, for arborescence. It could be anywhere along the limb. But typically patients will tell you, or people will tell you, that it's this one particular spot that it all started.
Interesting. Interesting. And pain is something that we don't associate. You only think of it as swelling and abnormal, fluid. And in the same area, what about the years that have gone by? How many years, and also how many node dissections if because you have more taken, does that have any indication of you being more at risk?
So then as soon as you fall into the category of axillary lymph node dissection, there's a cutoff typically, depending on the institution. It doesn't matter how many nodes are removed. So whether it's 6 or 14 for you to develop lymphedema. There's actually cases of lymphedema developing after sentinel node, which is sampling of maybe about 3 nodes, right? But that's a lot more rare. So the number of lymph nodes after a particular number no longer matters. And I like your question about when are you free? When are you out of that zone? Well, interestingly, we used to think lymphedema would happen within the first 2 years after surgery. As you look at our prediction model, we know that late predictors are things like diabetes and hemoglobin A1C that's elevated. That can happen anytime. That can happen 5 years, 10 years down the line. So there is no cutoff. There's no strict cutoff where, my chances of developing lymphedema are 0, unfortunately.
Interesting. Interesting, because we associate it with the surgery. And yeah, that's very interesting. So I'm going to go to your surgery presentation. And thank you. That was excellent. In terms of where you're getting the graft in the body, that area, what are the consequences and the healing and the because it's like a graft, and that in itself causes symptoms, etc. Is that something that is discussed with the patient? Because that too is going to be serving as a consequence after you've had all this surgery. And second part to this is with the longer surgeries, do you disqualify if you have comorbidities, if you're older, or if you have health issues?
So again, your questions are amazing, Kathy. So for the vascularized lymph node transplantation part, where we take lymph nodes from one part of the area to the other, I take it from the abdomen or the omentum because I know the chances of developing lymphedema in the deep abdomen are close to 0. But if you're going to take it from the groin, the neck, the thoracic area, then you can potentially cause lymphedema in those areas. So what we use is something called reverse mapping. So it's where you do 2 types of injections. You do a radioactive dye and a fluorescent dye, and sometimes patent blue dye, where you map out the lymphatics that are actually, the lymphatic lymph nodes that are actually draining that area. And you make sure you don't take those lymph nodes, because those are the lymph nodes that are the main lymph nodes in the area. But absolutely, if you don't do that, then and you take it from the groin, for example, you can actually cause lymphedema in those areas. Now, in terms of, I don't know if the question was also related to the breast flaps that we do, but in the breast flaps, the contacts that we do, I make sure to actually stay away from areas that are within the groin to prevent that from happening. But it definitely does happen where you can cause some lymphedema in the potentially in the groin area if you dissect in an area and you take lymph nodes that should not have been taken. So those are the things that I discuss. The other thing is for the long surgeries, typically age is not a contraindication. It's about your health and your comorbidities. Can you withstand being under general anesthetic for a period of 6 hours to 12 hours? And what I typically do if patients have a lot of comorbidities, I would send them to see anesthesia preoperatively or a cardiologist preoperatively. So typically I would not do this surgery on someone who is a smoker. Because smoking actually increases the risk of donor site morbidity, infections, and they can actually lose the flaps. So those are typically my contraindications. I also have a cutoff for BMI because I know that after a particular BMI, again, all those complications that we discussed increase, and that cutoff is a BMI of 35.
Okay, that's an amazing point there. And what about women that have had partial mastectomy, but enough to make a difference in the look of their breast? And they discuss with their doctor, well, we can wait. How long after can somebody wait and say, you know what, I'm done with looking at myself and it doesn't look right? How long after can you go and do some, I guess it's aesthetic at that point?
It's not aesthetic. It's still considered reconstruction. I would argue that you shouldn't wait. And the reason for that is because a lumpectomy or a partial mastectomy goes hand in hand with radiation. So if radiation were to happen, then the chances of going back and operating on that breast that is radiated can lead to a lot of complications. So ideally, I would say, please get your referral to a plastic surgeon immediately. Now, if, for example, that didn't happen, you can see a plastic surgeon at any time to discuss this. And then they have to talk about what are the possible options, knowing that you have had radiation in one breast. So the options are limited. I would not necessarily put an implant in that context right away, although I have done it in certain cases. But there are other options, things like fat grafting, things like bringing in some of the tissue. I think we lost Kathy, like bringing in some of the tissue to try to reconstruct those areas. So those are all things that we can do, but options are available, and you should see a plastic surgeon at any time.
Thank you. I did have a couple questions while we wait for Kathy to reconnect. One of them was on the length of surgery that you mentioned earlier and the comorbidities that would come with that. So we had actually someone reach out to us a few days ago who was concerned about nausea after such a long surgery and having to, lay flat during that recovery. What would be, do you have any recommendations on how they can sort of manage that nausea after such a long surgery?
So typically patients don't lay flat after this type
Okay.
of surgery. If anything, they're more, because the abdomen is so is tight, they're typically in like what we call like almost like a reflex type position where the bed is sort of, pillows are underneath. And then what's important is we have what we call like an ERAS protocol to be able to get patients out of the hospital as early as day 2 or day 3. And we're very particular about the types of pain control that we provide that actually prevents them from having to have a lot of narcotics, which typically cause nausea.
Okay.
And we have, very strong anti-nausea medications that we would put them on. So I think it all has to do with making sure your anesthesiologist is aware of that, and making sure that your team is also aware that you have issues with nausea after surgery, because there's definitely certain protocols that we can follow.
Okay, that's great. Thank you. And my second question, went back to you were discussing the lymphedema surgery that you specialize in and the work that you do at Yale. Do you have any understanding of what the access looks like for that particular surgery done in Canada at all? Do you know anything about that?
For the lymphatics, or for
Yeah,
which surgery? For the immediate lymphatic reconstruction, the
yeah,
lymphedema surgery? Yeah, so
either of them, yeah.
yeah, so unfortunately, there's really a paucity of people who are doing it in Canada. There's a center in, I think Vancouver is doing it. There was someone in London that was doing it, but he has now left for Halifax. Um, and I think it's possible that Toronto might be hiring someone who can do it. Um, Unfortunately, there isn't a lot of access in Canada to do it, but I think the best way to do it is to really discuss it with your surgical team, because they would know who's actually available to do it.
Okay, thank you.
I
I'll
got
pass it
that.
back to you, Kathy.
I I don't know what I missed, but I'm sure your answer was spot on.
Thank
Okay,
you.
so did you use any of the questions that I have here, Rebecca?
No, no, you can
Okay.
go ahead and use those ones.
I want to get back to another question that I had, if you don't mind. Implants. Can you
Yes.
speak around that? Because there's been like controversies, implants, breaking, leaking, not good for you. Can you touch on that a little bit?
Yeah. So the new implants, the new generation of implants, we've gone through multiple generation of implants over the years, even from when we've started, are a lot better. The type of implants are cohesive implants, where they're like gummy bear implants. So if they do rupture, they don't leak or go everywhere. We know for a fact that silicone is not dangerous to the body, okay? And we have a lot of studies looking at that. However, I talked about two things that we have to watch out for. Or, there are some women who have had textured implants that have developed this anaplastic large cell lymphoma that I talked about. And there are some women who just don't do well with implants. And that's called breast implant illness. Now, we can't really explain who will develop that. So the risks of anaplastic large cell lymphoma in patients who have textured implants are about 1 in 3,000. So that's still pretty high. Again, most surgeons have veered away from using any kind of textured device, whether it's tissue expander or implants. And the texture just really mean that silicone shell. So typically it could be smooth, or it could have little different variations on it. But I typically say implants are safe. The shelf life of an implant is about 10 to 15 years. It requires to be changed after 10 to 15 years, likely. But also that everybody can react differently to implants, right? And we need to be aware of that.
And in terms of, I'll stop after this question, go to a submitted question. In terms of follow-up exam for breast cancer and it's recurring, once you've had that reconstruction, for a lot of people, there will not be mammograms. That's not how you're going
Can't
to,
be bad.
correct me if I'm wrong, but I still think that's the way it is. But is it completely, you don't have to have any examination
You still
for,
need to have examination.
okay.
So if you've ever had a reconstruction, if it's implant based, you need to have examination about the recommendations by our associations are about 2 to 3 years, where the implant needs to be looked at either with clinical exam and imaging, so ultrasound or MRI. So those are absolute recommendations, and you should be followed
2 to 3 years?
every 2 to 3 years. Yeah. And then with regards to, so those are the American recommendations, absolutely, but by the American Society of Plastic Surgeons. In terms of, so would never be mammograms, because you should not have any breast tissue, right?
Right.
So similar with autologous. So in autologous based reconstruction, then I recommend that you still see your plastic surgeon every 1 to 2 years, because if recurrence was to happen, it would happen in the skin or the chest wall. So you need an exam. And then we would go on to do imaging from that perspective. But the imaging will never be a mammogram. It would be an ultrasound or an MRI, and typically an MRI.
Okay, good, good. So I'm gonna read some of these submitted questions. I have a couple because we still have a little bit of time. One question, submitted question, here it is. Is it possible to have a second lymphovenous bypass? Question mark, question mark. I had this procedure done, my mastectomy, and the removal of 22 lymph nodes. Within 6 months, I had lymphedema. Now it has almost been a year.
Yep. It's definitely possible, because the lymphovenous bypass that was done at the time of mastectomy, if I understand the question correctly, was for prevention. But we actually think that the lymphovenous bypasses actually stay open for about 2 to 3 years, and that after 2 to 3 years, you would require other surgeries for new connections to be done to actually help with flow. So absolutely, it is possible.
Can you explain what lymphovenous bypass is, just a little bit?
Yeah, it's when we take the lymphatic vessel that is less than 1 millimeter in size, and we find a vein that is nearby, and we connect them together so that the venous system can actually pick up that flow and that lymphatic fluid that typically accumulates around in the tissues.
Yeah. Like in your presentation, but I just wanted us to get refreshed on that. I have a second question. I am scheduled to have a DIEP flap surgery. I would be keen to have a lymph transfer at that time. Is this a common thing for a plastic surgeon to do?
So I would only do a lymphovenous bypass at the same time if axillary lymph node dissection was also done at the same time. Now, believe it or not, with a DIEP flap, we believe that lymph nodes are actually brought into place at the same time. So what I typically have seen, and what I do, is there's an area around there's a superficial vein that has some lymph nodes around it, and I can use that as vascularized lymph node transplantation along with my DIEP when I procure it. So absolutely, it's possible.
Okay. Next question. I have a lot of scarring and fibrosis from surgery and radiation. What is the likelihood that the flap surgery will help with some of the pain and discomfort that I feel in my chest and the axilla area?
Yeah, that's a great question. And that's a hard question to answer because I can't predict what the rate of you having the pain be alleviated. It really depends on how much of the scar is actually being removed. We do think that theoretically, again, like I just talked about, that having that, opening up that area, removing all that scar, putting in fresh tissue can potentially really help drain that arm, for example. But its direct effect to pain, I don't think it's really well studied currently.
Okay. And this is not a submitted question, but it comes to mind, like some patients were saying to me that they experience like an itchiness after years, in their arm after the surgery, with the nodes dissection. And it's not a pain, but it's like itchiness that they can't get to. What is that? And what do you do with that?
I mean, I think it's one of those things that is also hard to kind of like pinpoint. I think it's related to some injuries to the nerves around that area, to be totally honest. And then the only way to sort of alleviate it is maybe some nerve blocks, but things like, antihistamines and different things. And actually massaging might really help to relieve those symptoms.
And does vigorous exercise do anything to an arm that has had that, impact?
I think exercising is important in lymphedema and lymphedema care. Yeah, definitely. I don't think because the goal eventually with lymphedema, what can happen is the fluid accumulation leads to fat accumulation. It's important to continue to be active, to use your muscles, to use that arm. So I would never recommend, having a sedentary lifestyle or not using your arm or your leg.
And what about the braces? Years ago, women were wearing these colorful arm sleeves. Are those still something that are recommended? They are.
Absolutely. Those are part of the combined decongestive therapy portion that I talked about, which is really, that's what the treatment of lymphedema centers around. Compression, and so sleeves, either 3-layer bandages or bandaging, and sleeves. Absolutely.
Okay, so I have submitted questions. When you stage lymphedema, do you assign the patient a lymphedema diagnosis code for stage 0 so that they can start to work to prevent it from worsening? I think you covered a little bit of that, but I guess we can expand on that a little bit.
So yeah, I think it's really important to, first of all, to not dismiss people's symptoms, because even though the signs are not there, I think when someone is feeling heaviness in that arm with no swelling, I think that's probably the beginning of lymphedema. So there's certain things that we can do. So LDEX, which is spirometry, we could do like bioimpedance measurements. You could do ICG lymphangiography, which really helps you kind of look at whether or not the lymphatics are working or not. But I think it's important to at least be able to diagnose someone, because, and maybe just start the CDT right away, right, to prevent progression. So I think that's quite important.
The next question, if you have a minor lymphedema stage 0, I'm not sure if we answered this already. Are there any concerns with continuing weightlifting? What should be monitored during this activity?
No concerns with weightlifting. There's no contraindications to exercises. What you do want to make sure is that you also maintain like good hygiene. So if there's a break or trauma to the arm and that could promote infection, that's kind of what you want to make sure. Like, so, again, but there's no contraindication to exercise.
So this is not a submitted question, but does the arm react differently to trauma after you've had surgery? Does it almost not give you any symptoms sometimes, like burn? Let's say you got a slight burn from cooking or a paper cut or something superficial like that. Does it, how does that work on an arm that has had that surgery?
So, which type of surgery?
I get the question.
So if you have no nerve damage during the dissection, you should be able to have normal sensation anywhere in your arm. Now, immediately after your surgery, though, where your scar is, that sensation is diminished. So you have to be careful about like not having, anything hot on it or etc., or not going through trauma. But the limb itself should still have normal sensation. Anytime after surgery, in areas of scars, the sensation will change, right? Will be different.
Okay. So another question that we have from our audience, I had 2 sentinel lymph nodes removed. Do I need to avoid infrared saunas to avoid lymphedema?
I don't think there's any association between infrared saunas and lymphedema, but I think generally you have to be, again, like very aware of anything that causes trauma to your skin, right?
Right.
And avoid, and sun damage and things like that, right? And, like, which would increase your risk of skin cancer as well, but not particularly like infrared sauna.
Okay. Another question, what does pitting look like? Can you see it on the limb with the naked eye?
It's actually a sign that requires manual. So basically you press the arm or the limb and you'll see an indentation. That's pitting. And there's particular signs in the toes as well.
Okay. Have you ever seen lymphedema develop with lobulated nodule mass in left axilla with punctate calcification?
I think that's a very specific question related to cancer diagnosis. So the cancer diagnosis is not as important as the number of nodes that have been removed.
Okay. And I have a question from someone who is asking if you're able to share the name of the surgeon who came to Halifax.
Yeah, his name, let me just, I have to, his name is, his first name is Andrew. Let me just, I can find you, I can probably send you that information.
Okay.
I just want to make sure he's still doing it before
Okay.
I share that information.
No problem. And then
Andrew
if it
Simpson
is,
name, somebody
if it
put
is,
it
we
in the chat.
can, yeah, if it is, we can put it into the follow-up.
Perfect. Yeah, Andrew
Thank you.
Simpson is his name. Yeah.
So another question is, what about comorbidities like MS? I would imagine it's multiple sclerosis, where a long anesthesia could cause brain damage, like worsening the MS-related early senility.
Yeah, sorry, what's the question related to that? Like, are
I
they
guess
a candidate for surgery or are they higher risk for lymphedema? What is the question related to that in particular?
not specific. It just says comorbidity like MS, where a long anesthesia could cause brain damage. So I'm expecting it to be from that long surgery for
So,
reconstruction.
yeah, I've operated on patients who have had MS. It's not a contraindication. Again, it's about what medication patients are on and whether or not they can withstand a long surgery. It's not typically a true contraindication. I saw that Bonnie wrote that Dr. Simpson is teaching at Dal now, not perform. He is performing surgeries. He's actually a surgeon there. I'm just not sure that he's performing lymphedema surgery.
Okay. Next question. Do the recommendations for follow-up care post-reconstruction change if you have a genetic mutation? Example, imaging every year versus every 2 to 3 years.
It depends if you've had a mastectomy or not. Then after the mastectomies, the recommendations don't change whether or not you have a risk factor. What does change is some genetic risk factors also predispose you to other types of cancers other than breast cancer. So for example, ovarian cancer, endometrial cancer, and other things. So those have to be followed. Absolutely.
Okay. This next question, mastectomy, her mastectomy and simultaneous tramp flap reconstruction is now 26 years old. Oh, good on her. I was 35 and perfectly healthy at diagnosis. Are there any long-term issues that may arise in the long-term future?
No, I think if things are going well, I think that's amazing.
That's a nice comment and feedback. Somebody else is asking, I have heard that if there is arm extremity lymphedema present, then most likely there is also truncal involvement, like in the breast or axilla. Since the loss of feeling is frequently minimized in breast cancer patients, do you typically screen for truncal lymphedema when you see upper extremity lymphedema presenting?
We do. We can actually typically see it on ICG lymphangiography as well.
Okay. Next question, for compression therapy as a prevention strategy for someone at risk for developing lymphedema, do you recommend having the whole arm in a compression sleeve? Is there auxiliary only compression garments? Do you recommend all BRCA patients to wear compression garments for post-op?
I don't recommend it for all, but I don't think it hurts, right? I think it's beneficial. Now, I've never really seen, or I wouldn't recommend compression to the axilla only. I think we would include the upper extremity, maybe not necessarily the hand. But I wouldn't exclusively do compression on the axilla.
And speaking of compression sleeves, I have a question around that. Are there online compression sleeves, better compression sleeves? Are there too many variations? How does one choose a compression sleeve?
So the best way to choose is through a referral by your therapist and to be able to actually get assessed and properly fitted. because the most important thing is to be properly fitted for the compression and then follow the recommendations.
Okay, that's very good. So final question before we do our final goodbyes. When are compression pumps recommended?
Yeah, so I've been sort of following a lot of the data on compression pumps. A lot of my patients actually get it approved by insurance. You know, we're insurance based here, and they really like it. I still think it doesn't take away from the manual lymphatic drainage, which is a little bit different. So I'm still following the pump fad. I think it's more of a fad. I think there's some, some studies on it. I think what we need are prospective long-term data on it, but I think it could be very beneficial. Now, I don't work for a pump company. I don't know anything about a pump company, so I'm not promoting that. But I think what I would love to see is more data related to the pump.
Wow. Okay. So now I'm going to give my goodbyes. And of course, this concludes our time for today's session. Thank you everyone for your questions and for joining us to learn about clinical trials. To learn about this post-op surgeries and lymphedema information. So I want to thank you, Dr. Haykal. You have been really helpful today in teaching us quite a bit of information. And I want to thank again our sponsors, Pfizer's Canadian Lymphedema Framework, Bayer, Tercera, and AstraZeneca. I want to thank those sponsors. And following this session, you will get a link to complete a survey to provide feedback on the session. Please consider leaving feedback as this helps us improve future sessions for attendees like yourself. Once the recording is available, Rebecca will share a link along with resources shared in today's session and resources available through the Canadian Lymphedema Framework. And with that, thank you again, Dr. Haykal. It was wonderful to help you. And hopefully at another, probably Q&A sometime. And everyone have a wonderful afternoon. And thanks, Rebecca, for putting this together. Good afternoon, everybody.
Thank you,
everyone.
everyone.
Bye.
Bye.